All right, let's dive into ovarian pathology. But we're not just going to read from a textbook. The goal here is to give you a solid framework for your exams, so you know exactly how to talk about this stuff when you're in the hot seat.
So, picture this. You're in your oral exam. The professor throws up a slide, looks at you, and says, go. That moment, that's what we're preparing for. By the end of this, you're going to have a clear, confident starting point and a logical path to follow every single time. No more panic.
So here's our game plan. We'll start with the basics of normal histology. Then we'll jump into the big tumor categories, epithelial, stromal, and germ cell. After that, we'll see how it all comes together in a real diagnostic case. And we'll wrap up with some high-yield exam questions and a killer summary answer you can use.
Okay, first things first. You can't spot what's wrong if you don't know what right looks like. So let's lock in our baseline.
It's a really simple but absolutely essential distinction. When you're looking at a slide of the ovary, you've got the outer cortex. That's where all the action is, with the follicles. And then you have the central medulla, which is basically the plumbing and support, full of those big, squiggly blood vessels. Getting your bearings here is always step one.
Now, before your brain even screams tumor, you have to run through your mental checklist of these common non-cancerous things. These are the great pretenders. Follicular cysts are super common. Endometrioid cysts, the chocolate cysts, are a telltale sign of endometriosis. And, this is a big one, remember that polycystic ovary is a systemic metabolic condition, not a neoplasm itself. All right, let's get to the main event. If you're going to get grilled on any category of ovarian tumors, it's going to be this one. These all come from the surface layer, the epithelium of the ovary. And this chart really tells the whole story, doesn't it? About 70%, a huge majority of all ovarian tumors are epithelial. They are the heavyweight champs here. So while you absolutely need to know about germ cell and stromal tumors, your study focus should reflect this breakdown. Now, this is a really critical concept. Serous tumors, the most common epithelial type, exist on a spectrum. You can start with the totally benign cystadenoma. That can then become a borderline tumor. It looks a little weird, but it's not invading yet. This is where you see mutations like KRAS or BRAF pop up. From there, it can become a low-grade cancer. But, and this is key, the most common and deadliest one, high-grade serous carcinoma, is really its own thing. It's aggressive from the get-go, and its signature is a p53 mutation. And that leads us to probably one of the biggest breakthroughs in GYN pathology. We used to think high-grade serous cancer started in the ovary. We were wrong. Turns out most of them start right here, as something called a stick lesion in the fingers of the fallopian tube. A cell gets a p53 mutation, it grows a bit, and then it literally just falls onto the ovary and sets up shop. So get this, the most common ovarian cancer doesn't even start in the ovary.
Okay, time for some rapid-fire associations for your exam. If you hear huge, multiloculated cysts filled with mucus, you should immediately think mucinous. History of endometriosis, your brain should go to endometrioid or clear cell. And if you see cell nests that look like they belong in a bladder with those little grooved coffee bean nuclei, that's a Brenner tumor. Lock these buzzwords down.
Okay, let's switch gears and cover the other important categories. Now we're talking about tumors that come from the ovary's support structures, the stroma, and from the cells that were destined to become eggs, the germ cells.
A classic exam question is to compare the two types of granulosa cell tumors. For the adult type, remember it makes estrogen, so the patient might present with postmenopausal bleeding. Under the microscope, you're hunting for two things: Call Exner bodies, which are these cute little rosettes, and those telltale coffee bean nuclei with the groove down the middle. The juvenile type, on the other hand, you see in kids, and its nuclei are just round, no grooves.
Here's another super important distinction: mature versus immature teratomas. So a mature teratoma, or a dermoid cyst, is benign. It's the one famous for having stuff like hair, skin, and even teeth inside. But an immature teratoma is malignant. And the single most important thing you look for to make that call is immature neuroepithelium. The moment you see that primitive, embryonic-looking brain tissue, the diagnosis, the grade, and the treatment plan all change. It's a game changer.
For the other big germ cell tumors, just know the one key thing. A dysgerminoma is basically a seminoma of the ovary. Think big sheets of cells that are OCT4 positive. For a yolk sac tumor, the one thing you need to know is the Schiller-Duval body. It's pathognomonic, looks like a tiny glomerulus, and stings for AFP. An embryonal carcinoma? Well, it just looks really, really nasty and primitive.
Okay, so we've met all the players. Now let's put it all together and think like a pathologist. How do we take a few clues and get to a solid diagnosis? So here's a classic scenario.
You get a case, a young woman with a mass, and her serum AFP is high. Right away, your diagnostic gears should be turning. Young woman points you toward a germ cell tumor. Elevated AFP narrows the field down dramatically.
And then you look at the biopsy, and you see these very specific little structures. A blood vessel in the center, wrapped in tumor cells, sticking out into a space. What is that? What's the name for that classic feature?
And ding, 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 that's a Schiller-Duval body, and that clinches it. The diagnosis is a yolk sac tumor. See how we connected everything? The clinical presentation, the lab value with the elevated AFP, and the pathognomonic histology. Then you'd order an AFP stain just to prove the tumor cells are making it. That is the complete diagnostic workflow.
All right, let's bring it all home. How do you take all this information and present it in a clear, concise, and impressive way when the pressure's on?
You are very likely to get a question like this. A great answer doesn't just define it. You have to explain its significance. You say, STIC has completely revolutionized our understanding. It's the precursor for most high-grade serous carcinomas, and this discovery is changing how we manage high-risk patients, often leading to preventive fallopian tube removal. That connects the pathology right back to patient care.
This question is all about the details. So you say, histologically, high grade has wild, pleomorphic nuclei and lots of mitoses, while low grade looks much more uniform. But more importantly, molecularly, they're two completely separate diseases. Low grade uses the KRAS/BRAF pathway, while high grade is defined by p53 mutations and massive genomic instability.
Ah, the spot diagnosis. This is a softball if you're prepared. Coffee bean nuclei plus Cal-Exner bodies equals adult granulosa cell tumor. Every time. And for the second part, what hormone? Well, it's made of granulosa cells, so it's probably pumping out estrogen, which would explain symptoms like postmenopausal bleeding.
So back to that first scenario, the professor says, start talking. This right here is your model answer. This is your 2-minute drill. You start broad with the main classifications, you zero in on the most common one, epithelial, and you show you're up to date by mentioning estic lesions. Then you quickly contrast with the other categories and finish strong by emphasizing the need to integrate morphology and IHC. It's a structured, comprehensive, and impressive answer.
And finally, something to chew on. We've mastered the primary tumors, but the ovary is also a popular place for cancer from other sites to land. So how would you tell the difference between a primary ovarian tumor and a metastasis, like a Krukenberg tumor from the stomach? That's the next level, and this foundation is exactly what you need to start tackling questions like that.